All right, if you're in medical billing, you know what's going on. The GLP-1 wave is here, and it is huge. It's changing everything for patients, for sure, but for us, it's a total storm of new coding challenges, prior auth nightmares, and reimbursement headaches. So today, we're going to cut through all that noise and give you the clear, actionable guide you need to actually get these claims paid.
I mean, how true is this? This quote just hits so close to home for anyone working in the revenue cycle, right? The administrative battle to get these treatments covered can feel just as tough as the patient's own health journey. It's a massive challenge, and we are all right there in the thick of it. So let's get right to it. Here's the deal. Payers are watching these claims like hawks. Why? Well, it's pretty simple. These drugs cost a ton of money, and everyone is using them. That combination means any little mistake in your documentation or your coding is a giant red flag, making GLP-1s one of the hottest targets for audits, takebacks, and denials right now. So here's how we're going to break it all down for you, following the exact workflow you use every day. We'll start with why this is all happening, the billing boom. Then we'll get into the nitty-gritty of coding, solve the prior authorization puzzle, navigate those tricky payer audits, and then take a little peek at what the future holds. First up, let's set the scene. You gotta understand why this is such a big deal to really master how to bill for it. This isn't just some new drug we have to learn to bill for. No, this is a total game changer in how obesity is treated. And you, the biller, you're right there on the front line. So what exactly are we billing for? Well, these GLP-1 drugs basically mimic a hormone that's already in our gut. They do a bunch of things. They help with insulin, they tell your brain you're full, they slow down digestion. You're seeing them prescribed for type 2 diabetes with names you know, like Ozempic and Mounjaro, and for chronic weight management as Wegovy and Zepbound. Knowing which drug is for which diagnosis, well, that is absolutely everything. Okay, now let's get into the real nuts and bolts of your job, getting the codes right. This is where you build the whole case for medical necessity. If you get this foundation wrong, trust me, the claim is pretty much doomed from the start. And things are getting even more specific. Starting in October 2024, the CDC is rolling out brand new E-codes for obesity, broken down by class. Now here's the key thing you absolutely have to remember. You must use these new E-codes together with the right BMI Z-code. It's that combination that paints the full clinical picture that payers demand. Look, I cannot stress this enough. The body mass index, the BMI, is the absolute cornerstone of your claim. I mean, almost every single payer requires a documented BMI before they'll even look at a claim for these drugs for weight management. If that BMI isn't calculated and coded on the claim, you might as well just expect that denial to come right back. So let's break down the codes you'll be using. For your type 2 diabetes patients, it's the standard E11 codes you're used to. For obesity, it's that crucial combo, an E66 code plus a BMI-Z code. And hey, pay close attention to prediabetes, R73.03. We put it here because this is a huge trap. Most payers will flat out deny claims for these expensive drugs if that's the only diagnosis you've got. You know, it's not always just about the drug itself. A lot of payers want to see that the patient is also getting counseling for lifestyle changes. To bill for that, using a code like G0447 for Medicare, the provider's notes have to show this 5 A's model. They've got to assess, advise, agree, assist, and arrange. It's how you prove a comprehensive treatment plan is really happening. All right, you've got your codes lined up perfectly, but now for the next big hurdle, the prior authorization puzzle. This is where being meticulous with documentation and really understanding each payer's policies, that's what makes you a billing superstar. Now, before you even think about submitting that PA, you have to ask one big question. Is this a medical benefit or a pharmacy benefit? Most GLP-1s are taken at home, so they fall under the pharmacy benefit, meaning you don't bill for the drug itself. But if it's given in the office, it becomes a buy and bill situation, hitting the medical benefit. Getting those two mixed up is, you guessed it, a fast track to a denial. Payers are absolutely going to make you jump through some hoops. You'll need to show the confirmed diagnosis, the documented BMI, proof that the patient has tried lifestyle changes, and often proof that cheaper drugs didn't work. And to keep the drug covered, they'll want to see results, like the patient losing at least 5% of their body weight. So what do you do when that standard prior auth form just isn't cutting it? This is where a strong letter of medical necessity becomes your secret weapon. It lets the doctor tell the patient's full story, connecting all the dots to prove exactly why this particular drug is medically necessary for this particular patient. It can be a real game changer. Okay, let's talk about the part of this process with the highest stakes. Staying out of trouble with payers and, most importantly, navigating the super specific and pretty unforgiving rules of Medicare. Okay, listen up, because if you only remember one thing from our entire discussion, make it this. By law, Medicare Part D does not, I repeat, does not cover drugs prescribed for weight loss. It's what's called a statutory exclusion. Billing Medicare for something like Wegovy for obesity is a major, major compliance risk. You just can't do it. And here's what that rule looks like in the real world. If a patient has type 2 diabetes, yeah, Medicare Part D will likely cover their Ozempic or Mounjaro. But if the diagnosis is just chronic weight management, their sister drugs, Wegovy and Zepbound, are a hard no. It can be the exact same medication inside, but for Medicare, the reason for prescribing it, the indication, is everything. So what's going to trigger an audit? Well, the high cost and the fact that everyone's using them already puts a target on these claims. From there, auditors are looking for specific red flags. Using the wrong diagnosis codes, forgetting to document the BMI, any hint of off-label prescribing, and of course the biggest one, billing any weight loss drug to Medicare. To help you out, think of this as your denial prevention checklist, a little pre-flight check before that claim goes out the door. Is the BMI on there? Is the PA approval attached? Did you double-check that this specific drug is covered for this diagnosis by this payer? A couple of minutes here will save you hours of headaches later on. All right, let's wrap up by looking at what's coming down the pike. This whole landscape is changing, and it's changing fast. And some of the biggest changes are being driven by the biggest payer in the game, Medicare. So a pretty big shift is on its way. The law itself hasn't changed, but CMS is getting creative. Starting around April 2026, Medicare is planning to use special projects to start covering these drugs for obesity if the patient also has related health issues. Now, this is kind of a workaround for now, but it's a huge signal that a major formal change in coverage could be coming. And all of this leaves us with a really big question for the future. As these expensive, life-changing drugs become the new normal, your job is changing too. You're not just a coder anymore. You are now a guardian of your practice's revenue and a crucial advocate for getting patients the care they need. So the question is, how will you evolve to master this new, complex reality?